seats. Subsequently, progressively, our seat increased to 6 in 2010, and now we are having 8 students per year. Very important thing is our DM course in country is considered second important institute. That is why I am saying the DM students who are joining after GB1 is SMS. I think in the first 50 or 70 ranking, people join in SMS. So this is a big thing for us. And Dr. Vipin Mathur, presently is the principal of R&T, he is also our alumni. So this is also very happy thing to know. And in February 2022, we relocated from old building was, I think you must be knowing, in front of girls hostel and Charak Bhavan. That was the 3rd floor above the I department, old I department. This was constructed with help of JDA and Dr. Convenor. And then we shifted to new building. This was super specialty building in 2022. And we have a 8-bedded specialized ICU. We have 3 floors. We have on 3rd floor we have endoscopy suites. This is a picture of endoscopy suite. We are doing various endoscopy procedures. I think I will tell you that this is the high volume center. If you consider India endoscopy center, high volume is considered the number of procedures done. In the country, I think probably in the first 15 high volume center, we are doing always around 50 to 70 upper GI endoscopy, which include both diagnostic as well as therapeutic procedures. We are having 3 tables we are running simultaneously. We are doing colonoscopy. We have 2 suites of colonoscopy. We are doing 10 to 15, 20 colonoscopy per day. Various procedures, all kind of procedures probably which being done everywhere in the country. We are doing all these procedures. We have 2 dedicated ERCP rooms. We have 2 fluoroscopy. Last year, Dr. Deepak Maheshwari has provided us with new fluoroscopy and new equipment of ERCP. We have 2 suites. We are doing 72 ERCPs. And we are doing 10 to 15 ERCP. And this is very important because this is again very high volume center. And we recently got laser lithotripsy. That is, we are doing ERCP by doing laser lithotripsy. We are also doing spyglass. We can do pretty difficult binder stricture. Other than in what we have achieved, endoscopic ultrasound under Dr. Nicholas, this was in 2012. We have capsule endoscopy in 2012. We have single balloon endoscopy in 2016, fibroscan and manometer. Endoscopy ultrasound we are doing 5 to 10 per day. We are doing both diagnostic as well as therapeutic procedure. Recently we have started liver biopsy through US guided. We are doing US guided coil and thrombin for gastric varices. We are using labs. Instead, we are placing magnetic fluid connections. We have fibroscan. We are doing around 25 to 30 fibroscan per day. We have a manometry. We are doing esophageal, rectal, and biofeedback therapy. Recently, we have started doing third space. Third space is OM. OM is being done for ecclesia cardia. So we have done almost around 40 in last year. This is a new thing. We are doing it. And we have a spyglass. Recently we have got again, I think last week only, and we will be doing spyglass. We are doing bile duct disease and stones. We are doing, and we also started doing EMD and ESP. They are basically submucosal disease tumor to be removed by endoscopy. We have 3 units. We have around 100 beds. We have fully equipped ICU. Present faculty, again very important thing. I think except for one faculty, all are our alumni. And the second thing is the mean age of now after me, the next faculty is around I think 45. So it is a very young faculty now. I think they will be doing wonders in the future, and gastroenterology they will take to the new height. Dr. Prachish, he has done MD from AIMS, DM from here, multiple publications. He has done fellowship from Denmark. Dr. Gaurav is a professor. He has done multiple publication presentations. He has written multiple books in gastro, books and chapters. Dr. Mukesh has also done many publications. Dr. Sudhir, and he is also, because this is also important, I want to mention that he is the son-in-law of Dr. S. Sharma. So he is also some relation with the gastro department. and he has done multiple publications and presentations not only in India, but all over country and globe. And he is author of APASL. APASL is Association of Asia Pacific Liver Disease, and he has written books and chapter on this. Dr. Ashok is also a preliminary, and he has also done many publications, many presentations, and he has done remarkable presentation in US coil embolization for gastric varices. Dr. Kamlesh, who is going to present, who will discuss the case today, is also with us with many publications. We have newer faculty like Vidyadhar. We have Hemendra, which additional superintendent. He is doing excellent work for both administration as well as managing our department. We have Girish Dhakad as assistant professor, Dr. Rekha Vyas managing manometry lab. We have Vijay Patak and Dr. Shravan Kumar. We are also managing the National Viral Hepatitis B and C Control Program, which has been efficient. Academic, we have done multiple publications. I think in last 5 years we have done around 100 publications. I just want to say that we have published in high impact centers like endoscopy, GI endoscopy, gut, Journal of Gastroenterology, Hepatology, and Indian Journal of Gastroenterology. Currently we have done 3 ICMR projects are being done in our department. It's a big thing for us. And we have done multiple conferences from Dr. Nipalia sir and Dr. Rai sir. We have done multiple national conferences done in Department of Gastroenterology. For future vision, we require new year system already that's described. We want IBD liver clinic to be started. We want a big space for both for OPD for as well as indoors, so that we can accommodate more patients. We can efficiently manage, because the problem in new building is space. So if we have increased space, we can manage much better. Thank you very much. I will.
Thank you, sir, for taking us around in the journey of your master's department. And now I will call upon Dr. Devang, who will start up with the case.
A very good morning to the dignitaries on the dais, principal sir, esteemed faculty and my fellow colleagues. I, on behalf of the Medical Gastroenterology Department, welcome you all to the CLINICO Pathological Conference. We present a case for a 52-year-old male with abdominal pain, multiple joint pains and skin lesions. The primary discussant would be Dr. Kamlesh Kumar Sharma sir, and the primary presenter would be me. So, Mr. ABC, 52-year-old male, resident of Dosa, Hindu by religion, farmer by occupation, educated till primary school, belonging to the modified Kupuswami scale of lower middle class. He presented to us with abdominal pain associated with distension since past 1 month, multiple joint pains since 15 days, and multiple skin lesions for the past 15 days. With a significant background history of chronic ethanol abuse lasting for around 8 years, quantified up to 60 to 80 grams per day, and the last intake was 3 days prior to the presentation. On a case questionnaire, it was 4/4, and audit C questionnaire, it was 10/12, suggesting significant alcohol use disorder, and a chronic tobacco chewer for the past 10 years. So, coming to the abdominal pain, the pain was sudden in onset, epigastric, deep boring, associated with radiation to back, which was maximum in intensity at the beginning, around 10/10 on the Likert pain scale, which was aggravated by meals and lying down, and relieved by bending forwards and partially by IV analgesics. Abdominal pain was also associated with episodes of non-bilious vomiting and abdominal fullness. So this is the pain progression over a duration of 1 month. The initial pain was around 10/10 and was epigastric, deep boring. Over a period of next 20 days, patient experienced multiple episodes of abdominal pain requiring IV and oral analgesics, but he did not seek any formal consultation. Prior to presentation, 3 days prior, he had an ethanol binge and again presented to us with severe epigastric pain. Along with the epigastric pain, he had joint pain for past 15 days involving small joints, right hand first interphalangeal joint, second distal interphalangeal joint, right foot first interphalangeal joint and second DIP joint. Along again associated with multiple painful skin nodules on the back, buttocks and legs for 15 days. So coming to the negative history, there was no history of similar complaints in the past. no history of obstipation or ball of wind formation, jaundice, melena, hematemesis or altered sensorium, fever with chills, and no history of any urinary symptoms. The past history was negative for any medical or surgical procedures, and family history was insignificant. The personal history again significant was significant alcohol use disorder and chronic tobacco chewer. And bowel, the patient was constipated, bladder was normal, sleep was disturbed due to the abdominal pain, and appetite was reduced to 50% of the previous intake. On general examination, the patient was visibly sick with flank fullness and epigastric fullness, however with no evidence of scars, sinuses or dilated veins. On abdominal examination, the abdomen was warm to touch with epigastric tenderness, no evidence of palpable organomegaly, and on percussion there was shifting dullness. Air entry was reduced in the left lower zone and coarse basal crackles bilaterally. So coming to the approach and localization of the abdominal pain, the patient had a likely organic pain since it was severe in intensity, had associated night disturbance, and again there were IV analgesic use, effectively ruling out functional abdominal pain. Second, it was visceral because it was central, poorly localized, boring and severe, effectively ruling out parietal pain. And the organs of interest in this case, likely a solid organ because there is absence of luminal complaints, and the organ of interest in this case, likely pancreas. Again, the approach to abdominal distension. There was evidence of free fluid in the peritoneum, which was present as shifting dullness. Associated with abdominal pain, the etiologies could be either infectious, like tuberculosis, inflammatory, like pancreatitis, neoplastic, like pancreatic or abdominal or GI malignancies, vascular causes like HVOTO or portal vein thrombosis, or portal hypertension since there is significant history of ethanol abuse. So on the basis of clinical examination and history, the differential diagnosis is acute exacerbation of chronic pancreatitis with pancreatic ascites, chronic liver disease with pain likely due to portal vein thrombosis or spontaneous bacterial peritonitis, malignant ascites, or rarely abdominal tuberculosis. On preliminary lab investigations, the patient showed neutrophilic leukocytosis with an elevated GGT level likely due to the recent ethanol intake, and significantly elevated amylase and lipase levels in the range of 4,000 to 5,000. The total protein was slightly on the lower side, which was around 5.4. Albumin was 2.9. However, the viral serological markers were negative. The inflammatory markers were elevated with an elevated CRP of 21, ESR of 40 millimeter per hour, and LDH was 600 international units. There was evidence of hypoxia on the ABG, and the etiological workup for etiologies apart from ethanol was negative. On an ultrasound abdomen, the pancreas was bulky, edematous, dilated pancreatic duct with intraductal calculi. And there was evidence of free fluid in the hepatorenal pouch, pelvic space, perihepatic and perisplenic space, which was suggestive of moderate ascites. The patient underwent a USG-guided ascitic tab. The ascitic fluid was suggestive of a high protein, low SAG ascites, with predominant differentials being pancreatic ascites, tubercular ascites, and malignant ascites, which were ruled out one by one. AD was negative. Amylase was significantly elevated, 16,000 international units per liter, which was likely suggestive of pancreatic ascites, and malignant cytology was negative on 2 occasions. The chest X-ray showed left mild pleural effusion. The X-ray abdomen erect had low air fluid levels, ruling out intestinal obstruction, and the ECG was suggestive of sinus tachycardia. So, to come to a diagnosis of the abdominal pain, it looks like it's an acute exacerbation of chronic pancreatitis, which is likely ethanol related with pancreatic ascites, with no overt evidence of exocrine or endocrine insufficiency. However, the association with multiple joint pains and skin nodules still remains a question. So, to further discuss the joint manifestations, I invite Dr. Maheshwari, Assistant Professor, Department of Clinical Immunology and Rheumatology. Over to you, ma'am.
A very good morning to all. Thank you, Devang. So we'll move towards the history of joint pain. So this patient came to our OPD with the reference of a known case of acute pancreatitis, who's come with joint pain for the last 15 days. He had pain, swelling and stiffness involving the right ankle, right great toe, the right thumb and the right second finger. Along with this, his early morning stiffness, he could not delineate the duration, but said the pain was continuous in nature. He also had history of low back pain initially, which was intermittent, which increased on doing exertional activity. It got relieved at rest. There was no associated early morning stiffness. But for the last 1 month, this pain was continuous and he's associating it with the abdominal pain. He also had history of painful skin lesions or thickening, which was present over the right gluteal region in the calf. And history of alcohol abuse has been already elaborated by Dr. Deepak. So moving to the significant negative history for a patient who's presenting with a joint pain like this. He did not give any history of personal or family history of psoriasis, no history of any redness of eyes or blurring of vision, no history of preceding history of dysuria, diarrhea, oral or genital ulcer, loss of blood in stool or tenesmus, any significant family history of low back pain. He did not give any history of similar episodes of arthritis in the past, no history suggestive of any connective tissue disorder or of tuberculosis. So on examination here, I hope you can appreciate that there is swelling of the IP joint of the right thumb. There's almost an incomplete dactylitis of the right index finger, and there is swelling of the PIP joint of the right third and the fourth finger. Moving to the examination of the feet, you can appreciate that there is dactylitis of the right great toe and the right second toe, and also a bit of dactylitis of the right fifth toe. There is swelling around the mid-tarsal region, and there was swelling at the right ankle region too. So in order to approach a patient presenting with an arthritis of 15 days, I would like to review this table. So we approach an arthritis starting with demography. What is the age of the patient? Whether the patient is a juvenile patient, young to middle-aged or elderly. What is the gender? Whether it's a male patient or female. The duration of symptom, acute, subacute or chronic. Acute being less than 6 weeks and chronic being more than 3 months. What are the number of joints that are involved? Whether it's a monoarthritis, oligoarthritis or a polyarthritis. Whether it's an asymmetrical joint involvement or symmetrical. And what is the pattern or the topography of joint involvement? Whether the upper limb is involved or lower limb, the large or the small joints, whether the DIP joint is involved or not, the root joints are involved or not, or whether there is any axial involvement. What are the other articular manifestations in the form of enthesitis and dactylitis? And all this has to be seen in the background of other system involvement. So for our patient, he was a middle-aged male who had presented with an acute polyarthritis. By history it was oligo, but on examination we are finding it's a polyarthritis. Asymmetrical involvement involving both the lower and the upper limb, predominantly small joint involvement associated with dactylitis in the background of pancreatitis and skin nodules. So differential diagnosis for a patient like this first would be spondyloarthritis, especially reactive arthritis and psoriatic arthritis. Then I would like to bring about polyarticular gout, sarcoidosis, infections, especially gonococcal, infective endocarditis and viral arthritis, SLE and IgG4 related disease and PPP syndrome because of the background pancreatitis along with skin nodules. So moving to the preliminary investigations to delineate our diagnosis. As already mentioned, his APRs were raised. His uric acid was 6.8. The alkaline phosphatase was normal. Globulin was on the lower side. Blood cultures were negative. There were no vegetations on echocardiography. Synovial fluid analysis unfortunately could not be done as the fluid was not tappable. Chest X-ray did not show any evidence of hilar lymphadenopathy. ANA by IF was negative and HLA-B27 by PCR was negative. Moving to the radiological examination, as you can see there was soft tissue swelling present around the right index finger. And the right thumb is showing decreased joint space with presence of erosions. There were presence of erosions over the bilateral fourth metacarpopharyngeal joint and presence of erosion around the fourth DIP joint. This is an X-ray of feet oblique view. Again, we can appreciate that in the PIP joint there is decreased joint space along with erosions, and there is also presence of erosions in the tarsal metatarsal joints. The X-ray pelvis AP view was within normal limits. So now refining the diagnosis with this preliminary investigation, I would like to remove sarcoidosis as the patient though did have skin lesions and lower limb predominant arthritis, but there was no evidence of hilar adenopathy, and pancreatitis in the background of sarcoidosis is a rare entity. Again, infections were ruled out as there were no cultures were negative. There was no evidence of vegetations, and dactylitis in the presence of viral arthritis is a rare entity. Lupus, patient did not give any history suggestive of CTD, was a male patient, and ANA by IF was negative. Again, IgG4 related disease, the globulin were itself normal. So, an IBD related arthritis, as patient did not give any history significant of IBD, and ankylosing spondylitis is rare without any sacroiliitis involvement. So now we are left with these diagnoses, that is reactive arthritis, psoriatic arthritis, polyarticular gout, and PPP syndrome. So the points that are favor in reactive arthritis would be, it was a middle-aged man presenting with an acute onset oligo or polyarthritis with a lower limb predominant involvement. He had dactylitis, which is present in 17% of patients with reactive arthritis. And sometimes patient might not give a history of a symptomatic preceding infection, significant raised APRs, but that could be due to pancreatitis itself. And in the radiological part, we found that there were some irregular erosions, some periosteal reactions and spurs. Now the point against is that patient did not give any history suggestive of any preceding enteric or urogenital infection, no history of mouth genital ulcers or significant skin lesions like keratoderma pneumologica or Saxena balanitis. For psoriatic arthritis, again an acute onset oligopolyarthritis, both lower and upper limb can be involved. Dactylitis is also a very common entity in psoriasis, around about 30 to 40% of the patients can present. Here in radiology, we saw that there is almost a ray pattern of involvement of erosions with DIP involvement. The points against are again no personal or family history of psoriasis, but point to be noted is that 15% of the patients can present with arthritis without skin lesions. Again, no nail changes and no axial involvement. Polyarticular gout, middle-aged man with significant history of ethanol abuse, low limb predominant, the uric acid levels are more than 6.5. But points against no clinical tophi, no history of preceding acute attacks, no periarticular erosion significant of tophaceous gout on X-ray, and unfortunately synovial fluid analysis, that is the gold standard, could not be done. So today, and PPP syndrome is still hanging in the air. So for further workup, we had requested for an MRI of bilateral ankle and feet, which will be discussed in future slides. I would like to call upon Dr. Nausheen to discuss the dermatological work.
Thank you, Dr. Nausheen. I am Dr. Nausheen. I am going to discuss the drainage aspect of the case. This 52-year-old male was referred to us with the chief complaints of sudden onset painful skin lesions which were associated with abdominal pain and arthralgia. These skin lesions developed 15 days after the onset of abdominal pain, and they were accompanied with the onset of joint pain and swelling. These lesions first appeared over the shin and then they healed with pigmentation over a 2 to 4 weeks period. With time, other sites such as calves of legs and buttocks also involved. On clinical examination, there were few discrete painful, ill-defined skin lesions to erythematous subcutaneous nodules and case plaques of 3 to 4 centimeter in size. They were present over the both lower extremities and buttocks. On palpation, they were tender and firm, indurated nodules and plaques with mildly elevated local temperature. The overlying skin was smooth, shiny, and there were no hair loss. There was no sensory loss present over the lesions and elsewhere of this hair. There was no ulceration seen on the lesions. Here you can appreciate these lesions over the buttocks. They are raised plaques of skin color or slightly erythematous. Next picture shows lesion over the calf, and these are the pigmented lesions over the shin. At the time of presentation, the other associated findings are abdominal pain, joint swelling and pain, history of mild fever, chronic alcoholic, patient was chronic alcoholic, and there is elevated serum amylase and lipase enzyme, viral markers were negative, RF factor and NA were negative, and MON2 test was negative. and chest X-ray was clear at the onset of the disease. The clinical differential diagnosis for the subcutaneous nodules over the legs included erythema nodosum, pancreatic panniculitis, erythema induratum of basin or nodular vasculitis, polyarteritis nodosa, erythema nodosum-like lesion of Behçet disease, superficial thrombophlebitis, subcutaneous T-cell lymphoma, and infective panniculitis such as deep mycosis. First one is erythema nodosum. It is a very close diagnosis for this case. The points in favor is acute presentation of these skin nodules. There was no ulceration, no scarring, and it is associated with arthritis. The against is the lesions in the erythema nodosum are more erythematous. They heal with ecchymotic changes, and there are frequent recurrences. And mostly they are present in women, with typically present over the shin, and they are likely bilateral. The erythema nodosum can occur in a patient with recent history of any infections or drugs, and it is most commonly found in tuberculosis and streptococcal infections. In this case, tuberculosis was ruled out, and patient has no history of pharyngitis. ASLO titer were not done, and urinalysis have no findings, and viral markers were negative for this patient. Then second one is pancreatic panniculitis. The points in favor is again acute onset of skin lesions, and in pancreatic panniculitis the lesions were present other than sites of the legs. The lower legs are the common sites, but other sites can also be involved. In pancreatic panniculitis, constitutional symptoms are more commonly present than the erythema nodosum. Arthritis can be associated, and elevated serum lipase and amylase enzymes were present in this patient. And there is also abdominal pain and alcohol abuse. The points against are, in pancreatic panniculitis, the lesions may have oily or waxy discharge from the lesions, and there are ulceration and scarring. In this case, there was no such symptoms present. Then erythema induratum or nodular vasculitis. Again, in this tender nodules are present, and they are mostly present over the calves. The points against are, in erythema induratum, the lesions commonly found over the lower 1/3 of the leg only, and it has a chronic course and have a female preponderance, and they heal with deep atrophic scars. And in this case, Montagu's test was negative, and patient does not have all these findings. Then polyarteritis nodosa. The points in favor again, the lesions are tender nodules over the legs primarily, with constitutional symptoms and arthritis. The against the point are, in polyarteritis nodosa, the skin nodules are many in number. Sometimes they can increase in more than 100 in number, and they are less than 1 centimeter size and very deep. They are more palpable than the visualized. And there are, in polyarteritis nodosa, there can be presence of libido reticularis, and the presence, the vascular presence of appearance of starburst surrounding the nodule. Then superficial thrombophlebitis. Again, there are tender nodules over the lower legs, but they can be they are present in linear fashion, and there may be palpable cold feeling, and there is no sign of deep insufficiency also in this case. The erythema nodosum-like lesion in Behçet disease. Again, in Behçet disease, lesions can be tender nodules over the legs, and they are associated with arthritis also. But the points which are against for Behçet disease are, there is no recurrent genital or oral ulcers. Conjunctiva of the patient was normal, and the lesions of the Behçet disease not typically present over the legs. Then subcutaneous T lymphoma. T-cell lymphoma, again in this case the nodules or plaques are present over the lower legs, but lesions of these cases are painless usually, and there is no lymphadenopathy and no history of weight loss in this patient. The infective pericarditis, again in such deep cutaneous mycosis, patient can be presented with tender subcutaneous nodules, but they are usually present in immunocompromised individuals and without any constitutional symptoms, and the lesions in such cases are more widespread. So, from the diagnosis, differential diagnosis, polyarthritis nodosa, lesions of Behçet disease, superficial thrombophlebitis, subcutaneous T-cell lymphoma, and infective panniculitis of deep mycosis are ruled out on the clinical examination. Then we are left with pancreatic panniculitis, erythema nodosum, erythema induratum, and nodular vasculitis only. Out of these four, though all these entities are panniculitis in itself, but they have certain clinical appearances in common. After ruling out of tuberculosis, erythema induratum and nodular vasculitis was ruled out. So we were left with pancreatic panniculitis and erythema nodosum. They both can be associated with pancreatitis and arthritis. So on the only clinical ground, it is very difficult to make a differential diagnosis or a confirmed diagnosis. So we have taken a deep biopsy and sent it to the histopathological evaluation and specialist studies. Now I would like to request Dr. Mohammed Anas for the radiological aspect of the disease.
Thank you, ma'am. Very good morning, everyone. So, in next session, we'll be discussing about radiological findings. So, we received the patient for CCT abdomen. What you're seeing is post-contrast axial sections. So here it is showing edematous and bulky pancreas with prominent or dilated main pancreatic duct approx 4 mm, and there was significant peripancreatic fat stranding extending into lysosac omentum, mesentery, and even in left perirenal region. And incidentally, we also found there is mild thinning of renal parenchyma in the left compared to the right, and some focal calcitasis were also noted. Here, in this image, there was multiple calculi in the head region. Largest was approximately 7.8 mm, and the liver was absolutely normal. There was no like portal vein thrombosis or any SMB thrombosis. Here again in post-contrast axial section, in the lesser sac region, you can make note of two intercommunicating collections which were showing like fat stranding in the surrounding region as well. We also did MRCP for the patient for better rectal delineation. So here what you're seeing is T2, T2 axial and spare axial sequences. Here also you can note there is bulkiness and heterogeneously hyperintense pancreas with prominent main and accessory pancreatic ducts, and there was significant fat stranding as well. Here this spare axial sequence, the previously described collection in the lesser sac, you can make note with surrounding fat stranding. This is coronal section T2. Here there is a T2 hyperintense tract of collection noted to arise from the pancreatic head region. And in this zoomed up image, you can see there is communication with the MPD. Due to the MPD disruption, there is communication with the MPD, and it was traversing postero superiorly and blind ending in the lesser sac region. And there is note is also made of moderate ascites as well. This is a 3D hybrid sequence of GRE and SC, and this is a mid sequence. Here also it is showing the same finding. However, you can see at the blind ending site there is a ramification like a trident appearance, which indicates the potential for further extension and enlargement. So since it was in the lesser sac region adjacent to vessels, we gave contrast to the patient, and TP MRI was done. And what you're seeing is portovenous phase. Here This is a hypointense collection you are seeing, and this dot is the left gastric artery. So this collection was in close proximity to the left gastric artery. However, there was no vascular communication noted. So from the initial scan, we can summarize that it is acute and chronic pancreatitis with significant fat stranding and collection as described. So one of the collection was having communication with the MPD due to MPD disruption, and it was blind ending in the lesser sac region, and there was moderate ascites as well. So the patient also had multiple swelling in the small joints, especially in the lower extremities. And in bilateral ankle joint also had swelling, and right dorsum of the right foot also had swelling. So we did a USG. Other than the soft tissue edema, there was nothing significant found. What you're seeing here is the linear probe is kept along the long axis of the Achilles tendon, and this is Achilles tendon, and anterior to it is Heger's fat pad. This is edematous Heger's fat pad what you see. So we did MRI for better evaluation. So MRI bilateral ankle and foot was done. What you're seeing is right foot. Right foot. This is PDFS sagittal section, whereas these are axial, and this is T1 axial section. What here in the calcaneal tuberosity, you can see a patchy area of hypointensity, whereas that same region in PDFS is hypointensity surrounded by hyperintensity. Here also you can see it. It is adjacent to the attachment of Achilles tendon. However, the Achilles tendon was absolutely normal. To be precise, it was little anterior and superior to the attachment of Achilles tendon. There was no sign of enthesitis in this. Here again, this is distal tibia and fibula. What you're seeing here, this is tibia, this is fibula, and here also similar intensity lesion is noted in the tibia near adjacent to the fibular notch. This is head of talus, and here also in the head of talus, similar intensity lesion is noted, and in zoomed up image of the head of talus in the T1 section, there is a hyper intense band noted suggestive of fat component. This is left foot. A similar intensity lesion is noted in the navicular tuberosity as well, and the head of talus. So these features were suggestive of osteonecrosis, bilateral, asymmetrical, and multifocal. So in this is right foot, this is left foot. Here also you can note there is extensive Heger's fat pad edema, more in the left side, and there was no signs of enthesitis. The joint space was absolutely normal, and there was minimal synovial effusion. In this is left foot, this is right foot. If you closely look here, in the first MTP joint, there is minimal synovial effusion, and in the proximal phalanx, there is some PDFS hyperintensity periarticular. Whereas in right foot, again, first MTP and PIP has minimal synovial effusion, and in the distal phalanx is having subtle PDFS hyperintensity. So these features, we had two opinions. Since the patient already had multifocal osteonecrosis, this could be some early osteonecrosis with some reactive synovial effusion, or the second option was something called pseudodactylitis. So how will you differentiate between true dactylitis and pseudodactylitis? This table will be sufficient. This soft tissue edema, joint effusion, marrow edema is common in both. However, flexor tenosynovitis and enthesitis is rare or uncommon in pseudodactylitis, but it is very common or hallmark for true dactylitis. True dactylitis is seen in psoriatic arthritis and reactive arthritis, whereas pseudodactylitis is seen in pancreatitis, pancreatic carcinoma, and PPP syndrome. So, in MRI bilateral ankle, we can summarize there is bilateral asymmetrical osteonecrosis of variable size and pseudodactylitis stages as described, along with edematous changes in adjacent fat pad and subcutaneous tissue. So, since after rheumatological discussion, Rashima made these differential as finding like PPP syndrome, seronegative spondyloarthropathy, like psoriatic and reactive, and gouty arthropathy. So, by means of like radiological modalities, what are the core points seen in each is given in this. Like the X-ray, PPP, lytic lesions with preserved joints will be seen initially, and whereas in seronegative there will be sacroiliitis and syndrosmophytes enthesopathy, and gouty punched out lesions will be seen. In MRI, there will be osteonecrosis. Seronegative will have enthesitis and sacroiliitis, and gout shows tophaceous deposit. PPP will show pancreatitis, and USD it will show paniculitis, nodules, and seronegative will show synovial hypertrophy, and gouty arthropathy USD will show something called double contour sign. This is double contour sign. This dark structure is articular cartilage. Above it, there will be MSUT deposit. Due to MSUT deposit, echogenic line ring will be seen. So this is a long list of general differential, which will be seen in multifocal osteonecrosis. So, but correlating with our history of the patient, we can shortlist this into these 5, like alcoholism, diabetic mellitus, infection, paraneoplastic syndrome, and 3P syndrome. In alcoholism, the femoral head, knee, and shoulder will be involved initially, and the feet will be rare to involve early. Whereas in diabetic mellitus, it's actually a mimicker for osteonecrosis. It will midfoot joint will be involved. There will be fragmentation, dislocation, disorganization, and sclerotic changes. And in infection, there will be soft tissue collection and enhancement distinct from osteonecrosis. Whereas in paraneoplastic syndrome, it will show bone marrow replacement in MRI and underlying malignancy, especially pancreatic and lung will be shown. In 3P syndrome, there will be pancreatitis, paniculitis, and distal extremities associated with subcutaneous paniculitis will be seen. Thank you.
So to quickly summarize, so we have a patient who is a case of acute severe ethanol-related pancreatitis with CT severity of 8/10 and organ dysfunction in the form of acute lung injury and with pancreatic ascites, along with acute onset oligo to polyarticular inflammatory arthritis with evidence of erosions, bone marrow edema, osteonecrosis, subcutaneous edema, and sudden onset painful lower limb predominant skin nodules with no background history of infections or autoimmune pathology. So the question is open to the crowd. What would be the final diagnosis before we go ahead with pathology?
My suggestion is that only after clinical setting we should put up the things in flow. So everybody after investigation it is very difficult to narrow down the diagnosis. And I want to add the thing that HSP should also be included as a differential diagnosis. Because arthritis and pain abdomen may proceed and may not correlate at one point of the time. So HSP should be put up in the differential diagnosis of the thing. Second thing, CT shows the perinephric fat standing. So at least something should be there as a cause of acute pyelonephritis or emphysematous pyelonephritis. That should be added in diagnosis.
Thank you, sir. Duly noted, sir.
Yes.
Whole process of multi-system involvement, it happens in leukocytoclastic vasculitis. And leukocytoclastic vasculitis, the most common part, as Dr. Dhananjay said, it is Henoch-Schönlein. In Henoch-Schönlein, we have to get the skin biopsy, and skin biopsy comes out to be a sort of leukocytoclasis inside the blood vessels. So, although we are moving around pancreatitis-related problem, but leukocytoclastic vasculitis can involve pancreas, mesenterium, joints, and skin. Most important thing which probably we have missed, we have not touched kidney. Because in leukocytoclastic vasculitis, there happens to be this Henoch-Schönlein nephritis. Henoch-Schönlein nephritis leads to microscopic hematuria, and that part has not been done. Because microscopic hematuria means there is damage to the kidney. And whole process of leukocytoclastic vasculitis start with something. And the most common thing, because in history, episodes started after fall, that is upper respiratory tract infection, or viral gastroenteritis, or even sometimes HSP, or I mean to say leukocytoclastic vasculitis appear after taking some colored food items like cold drink or maybe alcohol, maybe after some sort of sweets which has got added colors. So we have to look for kidney also in this case, and in my opinion, after biopsy from any part, even mesenteric biopsy you can take skin biopsy, you will find leukocytoclasis inside the blood vessels. Thank you.
Thank you so much for the input.
Good morning, everyone. I'm here to present the pathological aspect of the case. We received a slide from the gastro department, and if we see it in the 4x view, lower magnification, here we can see the epidermis is predominantly like normal. It appears to be unremarkable here. And if we see, we can see some kind of inflammatory infiltrate in this area. So moving on to the higher magnification, that is the 10x view. Here the upper dermis shows mild perivascular infiltrate along the fat lobules. We can also see a normal line vessel here in this area. Moving on to the 40x view, the subcutaneous tissue shows infiltrate around the septum and the fat lobules. So this is the inflammatory infiltrate that we can see. It consists predominantly of eosinophils along with few lymphocytes and histiocytes. So these pink colored bilobe structures are the eosinophils that we can see. These are surrounding the fat lobules. And then on the 40x view, we also noted an area of fat necrosis. This supports the clinical context of pancreatitis. So coming on to the DDs, we reached 7 DDs. The first one was erythema nodosum. In this, inflammatory infiltrate is mainly present in the septa. It is characterized by vascular changes and septal inflammation. In this, no vascular changes were seen, hence it was ruled out. Arthropod bite reaction. Epidermis appeared normal and hence we ruled out arthropod bite reaction. Parasitic infection, we did not see any parasite in the slide received, so we ruled out parasitic infection also. Drug reactions, there was no history of any drug reaction seen in the patient and hence we ruled out drug reaction also. Eosinophilic fasciitis, we did not see any dense sclerosed collagen fibers in the subcutaneous tissue and hence this was ruled out too. So we were left only with 2 DDs, panicleitis and fat necrosis. So our final impression was panicleitis with fat necrosis.
So it was likely acute and chronic pancreatitis presenting as the triple P syndrome, that is pancreatitis, panicleitis and polyarthritis syndrome. Coming to the outcome, management and follow-up, the abdominal pain was initially managed conservatively with medical management, IV hydration and IV analgesics, and joint pain with oral NSAIDs as per need basis. Pancreatic ascites was managed with keeping the patient nil per oral, TPN for 7 days and octreotide 100 microgram TDS for 2 weeks. De-addiction referral was taken, anti-craving agents were added. However, in view of persistent ascites and new onset pericardial effusion, which was elevated amylase levels of 20,000 international units, and in this film you can see the extension of the fistula from the previous scanning. ERCP and pancreatic ductal stenting was done, and successfully the fistula was closed. And patient was discharged and had resolution of ascites, skin nodules and joint pain, and on follow-up at 15 days, 2 months and 6 months, patient is asymptomatic. This is an image from the ERCP showing leak from the main pancreatic duct. I now invite Dr. Kamlesh Kumar Sharma sir, Associate Professor, Department of Gastroenterology, for the discussion.
Good morning to all. As this is a clear-cut case of acute pancreatitis with pancreatic complications like ascites associated with other symptoms of other diseases like skin nodules and polyarthritis syndrome. This is a rare combination of triad of these findings. Triple P means pancreatitis, pancreatitis and polyarthritis. When we search out this triple combination, it is a very rare combination, and till date only 48 cases from the whole world has been reported in reputed journals, and all are indicating the same complaints, with major complaint of acute pancreatitis and arthritic changes are most common. It is the middle age complaints of these symptoms, and major risk factor is alcohol background associated with hypertension and diabetes in most common presenting associated risk factor, and only 2 to 3% cases have inflammatory or neoplastic pancreatic illness lesions, and 2/3 of the patients of triple P syndrome may be presented with mild abdominal symptoms or no symptoms, and in these cases pancreatitis can be diagnosed only by raised amylase and lipase level and radiological findings. And major causes of pancreatic pancreatitis is acute pancreatitis, chronic pancreatitis, and pancreatic malignancies. And less frequent causes are pancreatic divisum and pseudocyst. And when we go on the pathophysiology of this rare symptoms, the major clear-cut cause of this syndrome is still unknown. But some hypothesis is that because of pancreatic enzyme release in the blood, these enzymes like amylase and lipase reaches at the periphery, and in the skin it causes subcutaneous fat necrosis, as well as articular involvement may cause periarticular fat necrosis and synovial fluid inflammation, which may contain high cholesterol level as well as high amylase and lipase levels. And skin lesions, and these are clear-cut skin lesions which are typical of this triple P syndrome. And histology finding is typically showed in the patient is lobular pancreatitis without any signs of vasculitis or neutrophilic infiltration. And fat necrosis is typically showing those like adipocytes, which is pathognomic of this pancreatitis. These are pictures. And on joint manifestations, this is commonly symmetrical. Asymmetrical presentation occurs in 66% cases, polyarticular in 66% cases, and it mainly involves the lower limbs and ankle joints, and knee joints are most commonly involved. On X-ray findings, radiological findings has been already discussed in previous section. On synovial fluid aspirate, in this patient we could not take the synovial fluid because it was minimal. But if synovial fluid aspirate is done, it showed elevated pancreatic enzymes, cholesterol, triglyceride, and high neutrophil counts. This is the summary to shows the triad of pancreatic disease associated with skin lesions and arthritis lesions. And management of this remains on the treatment of the primary disease, which is pancreatitis, which is managed conservatively, as well as on management of pancreatic ascites was done endoscopically by ERCP and PD stenting. And patient was kept NPM and given injection of octreotide for 4 weeks, and gradually patient improved and discharged after 4 weeks on oral feeding. And on other treatment, management of other skin lesions and also arthritic lesions, this patient was managed only on oral analgesics and gradually improved the symptoms. We did not require any systemic steroids or intra-articular injections. And take-home message for this presentation is every patient with atypical symptoms require multidisciplinary approach for reaching the final diagnosis. Thank you. This PPT case has been sent to the publication and has been accepted in the Referred Journal of American College of Gastroenterology and will be published soon. Thank you. On the behalf of Gastroenterology Department, I thank you all the respected teachers and dear colleagues.
All of you, please stay here and ride on your respective seats to pay homage for the departed souls that we lost yesterday in the unfortunate tragedy. So can we all observe a minute's silence, please? Thank you everyone, and on behalf of the CPC team, I congratulate the Department of Gastroenterology for wonderful CPC today, and I would request all of you to join for a cup of tea outside. Thank you.